we can treat, then we have to face the immunosuppression we can have. Okay, so I will address you the use of mTOR-inhibitors in de novo kidney transplantations, not in maintenance patients. As stated by Prof Lionel, we will cycle 1 to cycle 3, and if we block cycle 3 there, we can block all the machinery, but in fact it's not so obvious. Yes, to some extent we block the downstream mTOR pathway, but there are other cycles. So, by the way, when we block mTOR pathway, we block translation processes, we block protein synthesis, and we block cyclic A. And therefore, we will prevent cell cycle progression from G1 to S phase. So, in which processes are involved translation, proliferation, and other things. So, with regards to translation, if we block mTOR pathway upstream, we will, by doing so, prevent CMV replication, and we will have a potential antiviral effect. This is true for CMV, this is true for BK virus, and maybe for EBV. So therefore, the mTOR-inhibitors have potential to inhibit some viruses. With regards to proliferation, if we block proliferation by blocking mTOR, we will block T cells, and therefore we will interact with the immune responses. And in addition to that, as mentioned by Prof Lionel, we may upregulate Tregs, and it was thought in the early days that by using sirolimus mTOR-inhibitors, we will upregulate Tregs, and therefore we can use CNIS protocol, blah, blah, blah. But it's much more complicated than that. Endothelial cells, as you know, endothelial cells are the culprit for blood cell proliferation, acidopathy, and so if we block endothelial cell, we will reduce vascular remodeling and fibrosis. And finally, because mTOR pathway is implicated in angiogenesis, as you know, mTOR-inhibitors are potent antineoplastic drugs for kidney, for renal carcinomas, for example, then sirolimus and Everolimus at high dosage are used for treating malignancies. And also, with regards to mTOR-inhibitors, it has been shown that they were able to treat Kaposi sarcoma and also to decrease the emergency rate after Pancreas squamous cell carcinoma. So therefore, because mTOR is pleiotropic, inhibiting mTOR will result in many effects. Okay. So what were the hopes when mTOR-inhibitors were launched? So in my center, we've been using mTOR-inhibitors in 1996 through phase 2, phase 3 studies for sirolimus and Everolimus, and on a routine basis since 2000. So we thought in those days that we needed some non-nephrotoxic drugs, because we thought that CNIS were nephrotoxic. I said we thought because in fact if we use less CNIS, there is no nephrotoxicity by investigators. We could protect from chronic graft injection in the setting of organ transplantation, and also we have anti-plastic effects and antiviral effects. So therefore, because de novo cancers and viral infections are so prominent in the setting of kidney transplantation, we thought that we might clear with this resistance. So when we stand 60 years later, so we have two mTOR-inhibitors, Cyclosporine and Everolimus, all the same. So obviously they are very close to each other. However, because of their chemical structure, their half-life is different. 26 hours for cytokines, 2 hours for Rapamune. So therefore, if you use cytokines and Rapamune, the target is achieved quicker. Loading dose is not necessary, whereas with Cyclosporine, if you want to deplete the target as soon as possible, you need the loading dose. Some side effects you have. Just have to modify loading dose and the target achieved sooner with you can assess draft levels by HPLC or EDIT. And on a routine basis, you can say that when you use you can assess the draft with 5, 15, 30, and then there is no need for me assess the drug because they are very, very, very stable with sirolimus, everolimus. When you are within the target, you are within the target for life, except if you use it as an addition to that or use of things like that or antibiotics. Otherwise, it's useless to monitor on a long-term basis the graft levels. And the safety profile of the side effects are a bit different. As you know, in the early days, using sirolimus, it was associated with more one-healing problems, more lymphocytes, more liver function, more intestinal difficulty, and all of the side effects were not observed with the cytokines. So there are two explanations for that. The first one is that with sirolimus we used to use loading doses, quite side effects. And secondly, because of the tissue concentrations of the drugs are not actually the same. So this is the rat model, which was published some time ago. So the rats were given immunosuppressant alone, or Everolimus alone, or sirolimus alone, or were given the combination of cyclosporine, sirolimus, and cyclosporine. And they looked at the interactions between two drugs, both in the blood level and in the tissues of the kidneys and the breast. So you see, at the blood level, if you assess if you draw a pharmacokinetic profile of cyclosporine alone or associated with Everolimus or sirolimus, there is no interaction at all. For Everolimus alone, Everolimus and cyclosporine, there is no interaction. Finally, sirolimus alone or sirolimus and cyclosporine, you've got no interaction. So at the blood level, they behave the same way. Conversely, the same rats, the tissue levels of cyclosporine, Everolimus, sirolimus were assessed by extracting from the tissues. So even kidneys or pancreas. And so, for example, the cyclosporine, if you look at the tissue concentration of cyclosporine within the kidney or pancreas, you see the tissue concentrations for the same draft level of the blood are slightly different, so the scale is the same, you see. And if you add Everolimus or cyclosporine, you do not increase the tissue concentration of cyclosporine. Conversely, if you add sirolimus, you double the tissue concentration of cyclosporine, both in the kidneys and in the pancreas. If you combine Everolimus to cyclosporine or Everolimus alone, if you look at the Everolimus tissue concentrations, you've got no interaction at all. Finally, if you look at the sirolimus tissue concentration, and this was shown long time ago by Rapamune, at the tissue level, it showed back in the kidneys, pancreas, in the rats. So if you look at the sirolimus tissue concentration, the sirolimus is given alone. So you've got the tissue concentration in the kidneys, in the pancreas. So you see it's almost very similar to the information obtained with Everolimus. Conversely, if you add cyclosporine, you double at least the tissue concentration of sirolimus. That is to say, there is no interaction between the blood. Conversely, at the tissue level, you've got a synergistic effect between cyclosporine and sirolimus. Conversely, you've got no synergistic effect between cyclosporine and Everolimus. And so this synergism might be of benefit if it belongs to immunosuppression, but conversely, it's detrimental with regards to toxicity side effects. Maybe, but it's something short yet, if we were looking at the pulmonary, the lung, the concentrations of sirolimus, Everolimus, and cyclosporine when they are alone or combined, maybe we'll find the same trends and the same results. And this might explain why with sirolimus you've got more pneumonopathy than with Everolimus. So just to keep in mind that in fact, even in the blood there is no difference at all. There goes no interaction, you got a good interaction at the tissue level, and this might result and explain some side effects. So, first of all, can we use sirolimus to CNI in kidney transplantation in the long run? So this was the Rapamune regime in which patients deal with transfusion recipients, sirolimus, cyclosporine, and steroids. You see high dose of cyclosporine in those days, and after 3 months, the patients were either maintained on the same regime, but at that time, cyclosporine draft were normal, 50, and sirolimus just over 5, or in overall cyclosporine was withdrawn. And sirolimus was and so when they look at the graft survival rate, you see you've got whose patients in whom cyclosporine was withdrawn. Conversely, you've got whose patients in whom cyclosporine was maintained. And so the clear message from that is that in fact having on more both sirolimus and cyclosporine will result in increase of the graft loss. And at this point the study was stopped. When comes the GFR, you see that GFR was playing whose patients in cyclosporine was withdrawn. And the blood pressure, mean of the blood pressure, the lowest one was 0. So the main message from that study was that if you combine in the long run cyclosporine and low dose, to sirolimus, low dose, it may have some nephrotoxicity impact. And this impact might be explained by that. You see, like that. And Pancreas did the same thing in the 90s with graft model. So it has some nephrotoxicity. Summary. So what was sirolimus-based suppression without CNIS? So the long, you've got your study that you will be publishing, I used to very soon, and its results. I don't have this data. So I just took the concept study data in 8 years. This is a French study. So patients were working transplantation to receive donors, they were induced with Tacrolimus, and then cyclosporine and steroids. And 3 months post-transplant, they were randomized either to be maintained on the same regime or to be converted from cyclosporine to sirolimus, and steroids were thereafter stopped at 8 months post-transplant. So, after a steroid withdrawal at 8 months, you see there was significantly more acute infections in those patients in whom there was no CNI, but only sirolimus and not. So at 4 years, graft loss was CNI. So now, at 4 years, still GFR activity untreated. You see that the GFR was significantly better in those patients in whom there was no cyclosporine on board. So these are the 8 years results that were published a few months ago. ITT population on treatment, you see on sirolimus for CNI, you see there's a huge difference in terms of GFR. On treatment, you see the difference is about 15 milliliters per minute in 8 years. So, okay, this was for sirolimus. Sirolimus plus CNI, it's nephrotoxic. You can use sirolimus. What about Everolimus and CNI? So, as you certainly know, Everolimus was developed in combination with low dose of CNI. Okay, so what are the requirements for Everolimus diagnosis in terms of when associated with CNI? It's not the same. So, why is that? Because cyclosporine does interact on sirolimus metabolism, and this increases the Everolimus blood concentrations. Conversely, Tacrolimus has almost no effect on Everolimus blood level, and so therefore, if you want to target the same Everolimus drug, let's say, if you are using cyclosporine because cyclosporine does interfere with Everolimus metabolism, you need twice as less Everolimus with cyclosporine as compared to with Tacrolimus, okay? To obtain the same draft level of Everolimus. So what does matter is not the daily dose, it's the draft level. So the first phase 3 trial, pivotal trial, that led to the approval of a cytokine in the States was that study in patients whereby patients were induced with Recipients. The control arm was receiving 2014 full dose and cyclosporine full dose receiving long-term draft levels of 15. experimental arms with reduced dose of cyclosporine, you see, after month 4, 50 to 100, and beyond month 6, 25 to 50. And Everolimus was given either 1.5 mg per day, and you can trough 3 to 8, or at 3 mg per day, with trough 6 to 12. Okay. And so at 1 year, with regards to the GFR, at 1 year, you see this was very similar, even though it was significantly better in that group, and that group was that of low Everolimus 1.5 plus low cyclosporine. With regards to the reduced exposure to cyclosporine, this resulted in significantly less side effects that we already know in the presence of full exposure to cyclosporine. So less tremors, less spasm, and less hyperventilation. So, what would renal function? So, renal function at 2 years in that study, so patients were classified according to MPA plus cyclo, Everolimus 6 to 12, the high that group, or 3 to 8 below Everolimus R. And if you look at the GFR, according to the RT, at 2 years, you see it was excellent with 3 arms, and it was better, slightly better in the Everolimus arms, 54 versus 51. But you would say, what about proteinuria? So in that study, proteinuria was prospectively monitored in the 2 years of the study. And so they analyzed the risk, hazard ratio for proteinuria greater than 300 mg per gram of creatinine, that is to say something significant, you see. And so when they compared MPA to Everolimus 1.5, you see there was no increased risk of proteinuria. Conversely, when they compared the high dosage of Everolimus versus MPA, you increase by 84% the likelihood of having high proteinuria, to say when they compared Everolimus trough level 3 to 8 or below 3, so this is 3 to 8 is the target, below 3 this is just a steroid drug, you see there was no difference at all. Okay. On the opposite, when they compared 3 to 8, which is the target value, to Everolimus greater than 8, the higher exposure, you increase your hazard ratio by 86% of proteinuria, is the same as that. Okay, so if you give high dose of Everolimus or high trough level, you end up with proteinuria. Okay? And in that study, diabetes, of course, associated with de novo proteinuria. Okay? So this is very important. This is important because for the first time, the institution of Everolimus low dose plus cyclosporine low dose was efficient first, and secondly, it was associated with very good GFR and almost no proteinuria. So this is a study, a recent study published in Germany, in which they took into account patients, pediatric patients, in whom there was a 6-month protocol biopsy. The patients were on CNI plus either NMF, right, or they were on low CNI plus Everolimus 2 to 6 plus PrEP plus Efficacy. And they all had protocol biopsy, were recipients of living donors symptoms. So, overall, when they look at the findings of 600 protocol biopsies, you see the protocol biopsy was normal in 41% of cases, IFTA in 20% of cases, and PK was nil, C4D was negative, and subacute rejection, we are discussing about subacute rejection, was present in 20% of cases. And now, when they look at the results according to having either MPA or Everolimus, you see subacute rejection was this is pediatric cases. Was only present in the setting of CNI plus MPA, no case in Everolimus plus CNI. IFTA was more prevalent in those patients on CNI plus MPA. GFR at 6 and 12 months was better in those patients with low CNI and low Everolimus. And finally, when we examine proteinuria, you see greater than 100 mg per deciliter, it was very low first, and secondly, this was the equivalent this study with kidney biopsies is very reassuring and very interesting in the way that, in fact, there almost no subacute injection in those patients with Everolimus. So this was a study that I co-designed with some of my colleagues in France. This is a CALLISTO study in which this was a development study that targeted ECD donors, so DC donors of poor quality, and we wanted to know whether adding on board Everolimus from the beginning or after 1 month would impair wall-healing processes, would interfere with delayed graft function and so forth. Because these ECD donors are at high risk of EGF, high risk of acute rejection, and so the question was, what about Everolimus de novo in that setting? So all the patients received Recipients, cyclosporine and steroids, and they were randomized to receive either full dose of cyclo, full dose of LPA for 1 month. Thereafter, my14 was replaced by Everolimus, and cyclosporine was decreased by 50%, or the patients were on reduced dose of cyclo, the CC2 around 500 to 700, right to say draft about 100, with Everolimus 312. And after month 3, cyclosporine A was further increased. So the primary endpoint was PPAR, was DGF, PPAR, graft loss, death, 1 complications. Okay, at month 3 and 12, so this was a 12-month study. So the primary endpoint was very similar at month 12, also month 3. That is to say, there was no difference at all with regards to having Everolimus on board from the beginning or after 1 month. One of the key issues was delayed graft function. These patients were at risk of delayed graft function. They were ECD donors. And you see, delayed graft function was very similar across the two arms, 24%. That is to say, I think Everolimus from the beginning didn't change anything. PPAR rate was very similar at 3 months as well as 12 months. Graft loss was similar. And one implication to remember, one people have sirolimus, wound-healing incidents, or fluid collection, or very frequent. In that study, with regards to wound-healing complications, it was similar across the 2 arms, fluid collection that were prospectively monitored at day 5, 10, 15, 30, and month 1 and 3 by echography. They were similar. So, no difference. And finally, no difference at all with PPAR, and no difference at all with GF4 at 3 months, 1 year. So that study demonstrated, at least to me, that in fact it was safe to use the Everolimus from the beginning with cyclosporine A, even in ECD donors. So this was another study to which my center participated, in which de novo transplantations were receiving Tacrolimus from the beginning, 4 to 7, just like the second trial, plus Everolimus draft 3 to 8 for 3 months. And after 3 months, the patients were randomized either to be maintained on the same exposure of TAC, 4 to 7, plus the same exposure of Everolimus, or exposure to TAC was reduced to have drafts below 3, that is to say very low dose of TAC. Okay? And as you can see, with regards to the draft levels of Tacrolimus, they were similar to formalization, which is normal, and afterwards, the draft was significantly lower in the very low TAC, but we were not within the pre-specified ranges, because as you know, as physicians, we are very conservative, and so we don't want to go further down. Everolimus draft levels were similar with the 2 groups at around 5.5. And the GF4 was very good actually in both groups, and it was significantly better than about 5 millimeters in favor of the very low TAC. And finally, in that study, we looked at the incidence of NDI, or onset of diabetes, at 1 year. There was a trend, but there was the p-value was not very significant. There was a trend to have less new onset of diabetes when the TAC was below 3 as compared to standard dose of TAC. So that study showed that it was was feasible to use low TAC, slow tolerance, and achieve very good results. So this is a 3-year study that was published recently that compared in novo patients, basiliximab, steroids, and either TAC low dose plus internet. This is the regime, or cyclosporine A plus Everolimus. So you see cyclosporine to the C2, it's 1.4, and it's very low cyclosporine. And at 3 years, when they look at the mean creatinine, mean EGFR, this was very similar to root to the difference of proteinuria. The differences were with regards to Everolimus, so like the lower in Everolimus patients, and the and more recently, just like the concept study or the ZEUS study, ZEUS study is a study in which after 4 months post-transplant, cyclosporine is stopped and replaced by Everolimus in one arm, whereas in the other arm, the patients are maintained with cyclosporine by 40 minutes. So, at 12 months and 2 years, the rate of rebound are very similar across the groups, and to say, in the group in which cyclosporine was maintained, or in the group in which Everolimus was maintained. At 2 years, the GFR was significantly better when cyclosporine was withdrawn. At 5 years, this was published recently, and the GFR was significantly better when the cyclosporine was withdrawn. However, at 4 years or 5 years, when they look at the power rate, in those patients who cyclosporine was withdrawn, you see there were significantly more PPARs between month 4 to 12, but also between month 4 to year 5. That is to say, the price to pay for this CNI-free regime with good renal function is that some patients end up with more acute rejections, even though there was no difference with regard to graft. To me, it means that CNI-free regime with Everolimus, it's not applicable, it's not safe, except patients having cancer. Standard patients, as I said, it's better to use low CNI crystal Everolimus. Okay. So what about de novo cancers? So I just recall that study that we published in the New Journal of Medicine. This is a French study whereby we took into account patients who were on maintenance therapy who have had at least one cutaneous squamous cell carcinoma, most skin cancers, and the patients were randomized either to be maintained on CNI or to be converted from CNI to sirolimus. And so this is a 3-year study, and now we just submitted the 5-year data, and we found the same thing. One way important that study was squamous cell carcinoma survival over 2 years. And what did we find? We found that recurrent squamous cell carcinoma was 22% on sirolimus as compared to 39% on CNIs. The median time to recurrence was doubled in most patients CNI. So, the conversion from CNI to sirolimus increased by 44% risk of recurrence. And the graft function is stable across the street. So, what about now? I will finish with mTOR-inhibitors and CMV virus infection. So this is a meta-analysis published by ROSTAING some time ago, 2006, in which she analyzed the risk of CMV infection during the first year of transplantation in those patients in whom immunosuppression was based on CNI plus metabolite or CNI plus mTOR-inhibitors. And you see that, in fact, having mTOR-inhibitors plus CNI increased by 51% the risk of CMV infection. This was a meta-analysis. This is a registry registry analysis from Spain, in which we include more than 1,400 patients, in which they examined the risk factors for developing CNP disease. What they found was that, in fact, having sirolimus-based immunosuppression decreased by 73% the risk of CNP infection. More recently, this paper from Daniel Renal, who wrote about CNP infection, he put 3 studies in which patients received cyclosporine, steroids, and either MPA or Everolimus. And he split out the patients, 2,000 patients, so it's a huge number of patients, 2,000 patients, and the patients were split out in those with no CNP prophylaxis and in those with CNP prophylaxis. And you see, the likelihood of developing CNP-11, that is CNP infection and CNP disease, was significantly increased when patients were receiving MPA plus cyclosporine as compared to Everolimus plus cyclosporine. And this was true without prophylaxis or with prophylaxis. And when you look at, when you exclude CNP diseases, so there are only CNP arenas, you see there was the same finding, that is to say, without CNP prophylaxis, having on board Everolimus significantly increased the risk of CNP arena. But this is a post-hoc analysis. So therefore, we can question the reason for the post-hoc analysis. In that study, this is a pivotal study that permitted the registration of Everolimus by the FDA 4 years ago. There was a post-hoc analysis of P. coli infection and CNP infection. You see that study at 1 year post-transplant. And they found significantly less P. coli and significantly less CNP infection in those patients having Everolimus as compared to MPA. That is only post-hoc analysis. So the first time was published very recently by Tedesco Silva, that paper. Tedesco is working in São Paulo, Brazil. This is the biggest kidney transplant center in the world, from roughly 1,000 kidneys per year. And in Brazil, that site is not reimbursed. So therefore, because it's not reimbursed, they don't use CNP prophylaxis. And so they designed this prospective randomized control trial in which the primary endpoint was CNP infection. So the primary endpoint was CNP infection for the first time at 1 year post-transplantation. And the patients were randomized either to receive ATG plus Everolimus plus Lutab, or Recipients plus Lutab plus Everolimus, or full dose of TAP, that's to say the Symphony protocol, plus MPA, and no CNP prophylaxis. So with regards to the trough levels of Tacrolimus, you see, when they had on board Everolimus, the trough were around 4. Okay? At the very beginning, they were 5 to 8, but after 1 month, they were around 4. And in the MPA arm, the troughs were, you see, around 7. And with regards to the Everolimus trough levels, when the patients were receiving Tacrolimus, the troughs were around 5. Okay? And these are the troughs of MPA, but as you know, MPA trough levels are meaningless. So the primary endpoint was at 1 year post-transplantation, the number of cumulative CNP infection or diseases. And as you can see, for the first time, the study is able to demonstrate in prospective fashion that you can significantly decrease the rate of CNP infection just by changing your immunosuppression without CNP prophylaxis. We are detecting 40% of CNP events, infections or diseases, when you are receiving TAC plus MPA, just like in the second trial regime, or below 10% when you are using Everolimus plus TAC. And for me, it's very important. In France, at the moment, we are conducting the same study, but it will be appearing later because we started later. And in France, we are just comparing these two arms, basiliximab to MPS to Everolimus with basiliximab. We don't have that arm, and we started a year ago, and so the recruitment period is finished. Follow-up will be finished in 1 year, and I can just tell you that for 5 patients we put in my center, we have had no CNP the infection in the Everolimus part as compared to a few in the MPS part. So that is to say, for me it's a big change, and I really think that based on this trial and on the trial we are conducting right now in France, we can skip serum prophylaxis, at least with low risk patient and anti-venous patients, by just replacing outside our Everolimus. So this was for COP. What was BKR? So this is a single randomized trial that examines the risk of BK virus infection with regards to the type of immunosuppression. So this study was conducted in Italy. Patients were randomized either to receive MPA plus cyclo, full dose of both, or low Everolimus plus low cyclo, okay? And the primary endpoint was at 1 year. The primary endpoint was the rate of the BK virus infection at 1 year. As you can see, at 1 year, if you have more Everolimus plus CNI, the risk of BK virus is 91% as compared to 9% as compared to 22% if you have CM9% BK. So the hazard ratio for BK viremia compared to 2 is increased by 71% in the NBA group as compared to the Everolimus group. So this is the first study, study to demonstrate that just by changing immunosuppression, we can significantly decrease the risk of BK virus infection. And that's it. Thank you very much.
So, I know that there's time restraint to you, so when you I mean, I don't want to long have the time.
I think the best thing is that your case presentation. My lecture was on a CAN, and so as you know, CAN is a messy subject. So with the CNIS and so forth. And so I covered, I think, TSN this morning, chronic activity infection. So we can share your experiences with this.
Right, I see. So because of time restraints, we have time for only one question. So as Rapamune mentioned, it's one question, so it's one question. So just a very simple question. How many patients in your center using mTOR?
Using?
mTOR-inhibitors.
Okay, so we have roughly, I think, at least, it's about 15 to 18% are mTOR-inhibitors. Okay? And as I mentioned this morning, as of next January, we change our primary